My paper is on assessment of risk factors for dry eye disease among doctors during COVID-19 pandemic and online survey in South India. Apart from the usual risk factors, the usage of face mask along with an increase in screen time could aggravate or lead to dry eye symptoms. And since the healthcare professionals were amongst those who had to spend more time wearing face masks during work, we plan to assess the prevalence of dry eye among doctors and the risk factors associated with it. A semi-structured pre-tested questionnaire was provided to all the participants using Google Forms. The survey had the following sections on demographic data, systemic illness, eye disease, any medications used, workplace, type of mask, duration of mask wear, whether they had taped the mask over the nose, and increase in duration of screen time, and McMoney's questionnaire and OSDI questionnaire. We had 209 participants, and the maximum participants were general physicians. 14.4% of participants were already diagnosed as dry eye disease before COVID. 31.1% of participants had an increase of 2 to 4 hours of screen time during the pandemic. The increase in screen time was due to entertainment or academic activities, including research. N95 mask was the most commonly used type of mask, probably because the survey was done among doctors, and the duration of mask wear was more than 6 hours in 61.7%. 92.3% of the doctors did not tape the mask over the nose, and air leak from nose to eye was experienced by 31.6% of the participants. The median McMoney score was 7, ranging from 0 to 24. Median OSDI was 6.25, ranging from 0 to 66.7. And the MQ score and OSDI had a positive correlation, with the p-value being significant, less than 0.001. Based on McMoney's, 12% participants had dry eye disease. Based on OSDI, 30.6% participants had dry eye disease, with 14.8% having mild, 9.1% having moderate, and 6.7% having severe dry eye disease. Logistic regression analysis based on OSDI score showed that presence of air leak from mask to the eye increased the odds of having dry eye disease by 2.2 times, the p-value being 0.02, and previous history of dry eye disease increased the odds of having worsening of symptoms by 2 to 2.3 times, the p-value being 0.04. So this study shows an association between ill-fitting face mask and dry eye disease. With the air escape through the mask to the eye, it can cause increased tear evaporation and hence tear film instability, which could lead to the inflammation and dry eye symptoms. This was supported by Mustafa et al. In his study, and our study also showed that persons already suffering from dry eye disease had worsening of symptoms, which was supported by Ariola et al. In his study. So with the waxing and waning of COVID-19, the use of face masks among doctors is likely to be the norm. Hence, dry eye dryness, irritation, visual symptoms may become a problem for a larger percentage of face mask users. Hence, we recommend taping of mask on the upper portion of the mask onto the nose to prevent the air leak to the eye, which can cause or aggravate dry eye disease. We also recommend taking frequent breaks whenever feasible and advocate the use of lubricants in people experiencing dry eye symptoms. So to conclude, there is a higher rate of prevalence of dry eye disease among doctors wearing ill-fitting masks, causing air leakage from nose to the eye, and also dry eye seems to worsen in people with prior history of dry eye disease. Since taping of the mask is a very simple and modifiable factor, we can recommend this, and we as ophthalmologists have the responsibility to raise awareness and educate people on the correct technique of wearing masks to avoid mask-associated dry eyes. Thank you.
So this is about, sorry. The conclusion, you said this is the mask-related dry eye. So the purpose was to show the improper wearing of mask causing the
dry eye.
Secondary dry eye, not COVID-19 causing.
No.
Okay, because the title was such that
So the assessment of risk factors, so we took into account the mask wear as well as the increased screen time. Actually, the study we did in 2020, so when we started using face mask, I was experiencing that that air leak, and also then we did this study, and all the mode of classes, lectures, I'm in a medical college, so everything was switched on to online mode. So we thought we should study how this is increasing the dry eye, and hence we did this.
So apart from the evaluation of dry eye, apart from OSDI and the scores, what all evaluation did you carry out when you were carrying out the dry eye, assessing the dry eye and the severity of the dry eye? Is this based on OSDI scores?
It's based on OSDI score.
Mainly based on OSDI score.
Only OSDI.
Yeah, the regression analysis, everything was done based on OSDI score.
And this questionnaire was directly taken or it was
The
modified?
OSDI was not modified, sir. We added our questions like the amount of duration of face mask, where the taping of the face mask, all that we added the questions, but OSDI we did not modify, it was as such.
What could be the possible postulation for like getting less dry eye with N95?
N95, our study had most of them wearing N95. Probably we conducted this only among doctors, sir.
Okay.
So you also talked about that whether what the screen time was related and what they were doing, and depending on that, this prevalence of dry eye. Can we have a look at the questionnaire? If you have that, the questionnaire that was provided to the doctors, what all questions did you ask them regarding the use of the mask as well as the screen time, or how did you? What I'm trying to get at is how did you assess the screen time, right?
Screen time we had actually divided into less than 2 hours increase in screen time apart from their usual one. So pre-COVID, like we asked how many hours do you usually spend, and during this COVID, what is the increase in screen time? So less than 2 hours, 2 to 4 hours, 4 to 6 hours, more than 6 hours. But in our study, we did not find any correlation with the screen time or the duration of face mask.
Okay. Next.
All right.
Thank you.
Thank you.
Please. Paralytic lag of thymus.
Good morning. Good morning, everyone. My topic for presentation today is clinical evaluation and management of paralytic lag ophthalmos, our study.
Louder, please.
Paralytic lag ophthalmos occurs due to weakness of the orbicularis oculi muscle and damage of facial nerve. There is incomplete closure of the eyeball. It's important to determine the cause of facial nerve palsy, as there might be life-threatening conditions like stroke, intracranial mass, or paraneoplastic disease. Other etiologies include infectious disease and idiopathic. The aim of our study was to evaluate clinically and treat the cases of paralytic lag ophthalmos. The period of study was 1 year and total number of cases were 11, and out of which 7 were male patients and 4 were female patients. Regarding the age distribution, 20 to 30 year we got 2 patients, 30 to 40 year 2 patients, 40 to 50 year 3 patients, 50 to 63 and 60 to 71 case. Regarding the cause of lag ophthalmos, idiopathic was 6 cases, associated with cardiovascular diseases 2 cases, and leprosy 3 cases. And the patients presented to us with the complaints like unable to close the eyeball in all the 11 cases, and watering 7 cases, foreign body sensation 4 cases, and red eye 3 cases. We assessed the strength of the orbicularis oculi muscle and corneal sensation was tested. On examination, conjunctival congestion was found in 5 cases. Both conjunctival and ciliary congestion were found in 6 cases. Exposure keratitis in 3 cases. Neurotropic keratitis 1 case. And when we record the visual acuity, 6/6 in 3 cases, 6/9 to 6/24 3 cases, 6/36 to counting finger 3 meter 2 cases, and less than counting finger 3 meter 3 cases. And regarding duration of presentation, within 1 week 4 cases presented to us, and within 4 weeks 5 cases presented to us, and within 4 months 2 cases. All the patients referred to neurology department for evaluation of the facial nerve palsy. Regarding treatment, it varied depending on the ocular surface involvement. Systemic steroid prednisolone acetate was given to 9 cases, and topical antibiotics, moxifloxacin, and lubricants like carboxymethyl cellulose, sodium hyaluronate given in all the 11 cases. Patients advised for lid closure during sleep. Tarsography was done in 3 cases, and palmaris longus tendon transfer was done in 1 case. So this is the case where lateral tarsography was done. This is another case where also lateral tarsography was done. We waited after giving systemic steroids and giving lubricants and antibiotic eye drops. We waited, and then we did the lateral. When it didn't recovery was not well, we did the lateral tarsography. To conclude, paralytic lag ophthalmos is a common condition. Majority of the cases respond well to systemic steroids. Antibiotic eye drop and artificial tear substitutes like carboxymethyl cellulose and sodium hyaluronate are useful. Voluntary closure of the eyeball during sleep with application of local antibiotic and vitamin A eye ointment was also useful. If persisting after 6 months, tarsography is very helpful. Thank you.
Hi, did you grade the level of flag ophthalmos? Did you grade the level of flag ophthalmos in all the cases and kind of try to assess which cases, did better depending on the amount of flag ophthalmos, and how many cases required tarsography even though the amount of flag ophthalmos was lesser?
Actually, most of the cases, yes, some of the cases, there were very mild degree of lag ophthalmos, which responded excellently to systemic steroid, and when it was slightly moderate, also responded to systemic steroid with topical drops, and when it was severe, it did respond to steroid, and we had to do tarsography.
You mentioned in conclusions that tarsography in cases persisting for 6 months. I think that's too long, because you have to see the sensation also. Sometimes if the sensation is not there and you have that kind of picture, you have to do immediately, because you have to prevent the damage rather than.
Yes, that's true. Most of the cases, actually, the corneal sensation was normal. So the cases we waited.
And the patients where we have got loss of corneal sensation total plus exposure, we have to do central tarsography rather than the.
Yes. Yes, in some of the cases, actually.
So, any imaging studies you did on these patients?
Pardon?
Any imaging studies you did, like an MRI brain?
Yes, MRI brain was also done. Actually, we referred all the cases to neurology department because to evaluate the case, the MRI was done.
So, what were the results in this in these
Actually,
cases?
most of the, since all the idiopathic causes, we found that the MRI was normal. Normal.
Yeah. So that is why when you started steroids.
Yes.
Okay.
You didn't got any case secondary to trauma or something?
Actually, we didn't get a case of secondary to trauma. That is also possible in case facial palsy, but in our study, it was not.
Or really any case of neoplasm or like that? No.
Neoplasm also we didn't get.
Thank you.
Just not related with this study, but I would just like to add that vitamin A ointment, although it is there in the market now for some time, but now some people are saying it's not very safe because it does cause some photokeratitis. So I don't know. Maybe you have to evaluate this ointment.
Okay, another study is to be done to evaluate the effect of vitamin A. Okay, thank you.
Next.
यहीं से नाम बता देंगे ना.
A very good morning, everyone. And the topic of my presentation is to determine the role of transcutaneous retrobulbar amphotericin B in COVID-19 related orbital cerebral mucormycosis. So it was a prospective hospital-based interventional study carried out during the second wave of COVID-19. Transcutaneous amphotericin B was used as an adjunct therapy along with other supportive treatment in patients of ROCM with orbital involvement after applying the inclusion and exclusion criteria. 7 patients were given the injections during the course of the treatment, but due to loss of follow-up, we are presenting 2 cases with ocular outcomes with post-injections and followed up till 6 months. So inclusion criteria was willing for the injection, those having signs and symptoms of ROCM, a nasal swab showing the aseptate hyphae, preserved vision with focal involvement of the orbit. Exclusion criteria: negative fungal biopsy, and patients with disfigured, painful blind eyes with frozen globe were best exonerated than to be repeated at RAM. So at presentation, the patient was subjected to multi-speciality evaluations, which included ENT, ophthalmology, general medicine, and nephrology. And ophthalmic examination, visual acuity, pupil erection, slit lamp examination, and the fundus with grading of ptosis, proptosis, and extraocular motility. And the patient was subjected to throat swab for COVID-19 RT-PCR, and the predisposing factors for invasive fungal infections were noted. Regularly, laboratory investigations were done. MRI was done, and the patient underwent FES under GA, and tissues were sent for histopathological examination. So injection protocols was, that is to a vial of 50 milligram of lymphocytes, that is 10 ml of distilled water was added to make a concentration, and 0.7 ml was drawn and diluted to a concentration of 1 ml with the concentration of 3.5 milligram in 1 ml by adding 0.3 ml of the distilled water. So under all aseptic conditions, after getting the consent of the patient, it was given, and patient received 3 doses of tram on alternate days. The first case is 36-year-old male presented with chief complaint of nasal stuffiness and nasal discharge for 10 days. He was a known case of uncontrolled diabetes mellitus on oral hypoglycemic since 2 years. On ocular examination, vision was 6/6, extraocular movement restriction of abduction in left eye with the normal ocular movements in the right eye. Pupils right normal size and reacting, the left showing the brisk reaction, and interior segment, the left eye ptosis with no proptosis. So dilated fundus examination was normal. So this was the MRI showing the bilateral ethmoid maxillary sinusitis, left optic nerve with retroorbital fat haziness, left optic neuritis, indentation and displacement of the left medial rectus from the lateral ethmoid cells. So we can see here the improvement after the 3 doses of the tram. So radiological improvement also after the 3 doses of the tram. The case 2, 40-year-old male with who presented to the Department of ENT with the chief complaint of bilateral nasal stuffiness and discharge. He was known case of diabetes on oral medication since 2 years. So on examination, the vision was 6/6. The right eye abductions were limited, and the left eye extraocular was full and free and painless in all the cases. And on MRI, we can see the bilateral maxillary sinusitis right more than the left with the involvement of the right sphenoid sinus. Soft tissue standing to the inferior and the medial aspect of the extraocular fat on the right side with hazy right medial rectus and inferior rectus. Brain showed no involvement. 3 injections were given, and we can see the improvement after the post-injection. So here the radiological improvement can also be seen. So after 4 months, he again presented, this patient, again presented with the pain and swelling in the cheeks. Blood sugars were normal. Patient was investigated again in detail clinically, microbiologically, and radiologically. He showed osteomyelitis of the right maxilla. It was the old sequelae of fold infection. So right maxillectomy was also done in this patient. So the conclusion, in our study we have treated all the patient with FS and amphotericin B, and it can be given in the limited ocular involvement, and it can be considered as a therapeutic adjunct in managing the cases of ROCM as a globe sparing intervention. Thank you.
Why did you prefer L-amphotericin B rather than plain? What was the advantage of that?
So because it has the availability issue, sir, at that time, and also it is because of availability and the cost issues.
Okay, it is supposed to be less toxic.
It is also less toxic, sir.
Did you observe any complications of this injection?
No, sir. In all the 7 patients, after giving the 3 injections, we did not see any complication. But ratherly, we were following regularly these patients, And for a long follow-up, only these 2 patients were available, so we have included. But no patient, we have seen no.
For how many months you followed up?
Yes, sir.
For how many months you followed up the patient?
So these patients came for 6 months. Others we lost to the follow-up, so I didn't show here.
So you mentioned the 2 cases.
I have mentioned here that only the 2 cases.
Right.
So this, out of the 7 patients, was there any telephonic communication to understand whether they had, they had loss of life or some severe comorbidity? What was the reason why they didn't follow up, or any of these patients underwent exenteration out of the 7?
Ma'am, we tried, but I will also follow them with the ENT people also. Because of the photo and the picture, CT, MRI, these only these patients we have of these patients. So I have included to show the improvement. Because MRI scan, many patients didn't get the MRI scan after the post injections. So these were the few limitations for which.
Okay.
Thank you, sir.